here with two very influential ladies, one from the Netherlands, one from Australia, both working in dentistry, but both also very passionate about breathing, apnea, and especially children's health. And I'm very grateful that I can have both of them here, but especially Dr. Shereen Lim from Australia, who wrote this beautiful book. It's called Breathe, Sleep, Thrive. How airway health can unlock your child's greater health, learning, and potential. So a super interesting and super important topic that we're going to be talking about the coming hour. And I'm very grateful that we can pick your mind, Shereen. And if you will, please give us an introduction that you feel is worth knowing for the audience here in the Netherlands about your background and your passion for this topic.
Yeah, so I'm a general dentist for 25 years, and I developed an interest in sleep and breathing because of my husband's snoring. So it was about 12 years ago. His snoring was really bothering me, and I got out of bed. I was so frustrated. I was aware that dental appliances worn during sleep could help improve breathing and sleep, and I wanted to be able to learn more about that to help myself and other spouses that were in the same position. And so I enrolled in a graduate diploma in dental sleep medicine and became involved in the management of adult snoring and sleep apnea. And I just started to question, how come we are offering this Band-Aid solution? We're repositioning jaws. How come we just don't grow jaws better in the first place when children are younger? And I'd come across work by Dr. Christian Guilleminault, where palate expansion could improve breathing and sleep. And it makes total sense. I had young children. Why don't we grow children's jaws when they're young? Why do we have to wait till age 12 when their jaws are finished growing and then do braces, often taking out teeth? I wanted to be able to optimize jaw development. And so that's when I learned about early interceptive orthodontics. And then I actually met Dr. Christian Guilleminault in 2014, and I told him his work has inspired me to learn more on early interceptive treatment. And he said, if you're doing orthodontics, you're too late. And I had no idea what that meant, but basically it's form follows function. So when the jaws don't grow well, it's a reflection of poor oral function or oral dysfunction in the earliest years of life when the jaws are growing most rapidly. And so that really highlights we need to establish good nasal breathing, look out for things like tongue tie, and getting the muscles to work well. And so that's how now, moving away from adult treatment, I've really become involved in promoting airway health for children, helping them breathe better and their jaw structures grow well through advocating the mechanical benefits of breastfeeding, involved in tongue tie management from infancy through to adults, as well as early interceptive orthodontics and myofunctional therapy in our practice.
Yeah.
Wow, what a beautiful journey to be on. Nurcan, I'm guessing you will have enough questions or topics related that you want to talk about.
Yeah, I do. I do have a lot of questions.
Please give the viewers also your short introduction that everybody knows your background here in the Netherlands, and then take it away.
Yeah, my name is Nurcan Yilmaz. Thank you for participating today. And I studied dentistry in Amsterdam at the university. And basically 2 years later, I started doing my specialization for reconstructive dentistry. And as you just said, that's a way of thinking about form follows function. So I kind of like treated every patient in a reconstructive way. And all of a sudden, when I got married in 2017, I got to know my husband, and he sleeps next to me, and he heard me snoring. And that started my journey around this topic. And as the same as you, Shereen, I started having a look how it works with adult people. But by analyzing myself during my study, during the orthodontic blocks, and during whenever I had the chance, I found out that I had a dished in profile, and that dished in profile means a lot of problems that existed during the latest years, not during my younger years, but in my later years. And all of a sudden, my aesthetic problem became not just an aesthetic problem, but a health problem. And since it's a health problem, I kind of like digged into it. And since a few years, we're finding a way how to not respond as you do on an older age, but on a younger age.
Yeah, beautiful. Well, take it away, Nurcan. Questions or topics that you have that you want to elaborate on with Shereen.
Yeah, Shereen. Now, one of the first questions I have, when you first had the chance to figure out how it works with children, when parents come to the practice with their children, they take their babies with them in, we kind of like see them sometimes at 6 months, sometimes at 9 months. And the first question then that comes up is, I already digged into your book and in the literature, we all know that breast sucking is way more intensive than the bottle. So we kind of like try to tell every parent, try to do it if you have the chance. Of course, we cannot oblige anyone. It's not that we can do it, but we kind of like try to tell them why it's so important. And then the first question they ask, okay, if my child has a pacifier even before the tongue tie, because the tongue tie is something in Netherlands that maybe 50% of hospitals have a look at and maybe 50% don't. So that's something we take with us. But the problem is we see the children in their mouth from an age, I guess, 2.5, maybe 3 years old is already way too late because you want to do it in the first weeks. But when they come in, they get the pacifier. And then the first question is, when do you stop the pacifier? And why do we use the pacifier? Is that an answer you can give to me?
When do we stop it? Well, yeah, obviously, if we consider that the mouth is growing the most rapidly in the first year of life, and we want that tongue lightly suctioned to the roof of the mouth to stimulate broad palate development, we have to pay attention to these habits in the first year of life. And a lot of people think that they only use a pacifier during sleep, but the problem is that the duration of sleep is, more than half the day. So it really is altering the way that the tongue is supposed to work. And this has a large impact on the way the jaws are growing, so that we know that children that use the pacifier by age 4 have a very increased risk of crossbites and narrow palates. So when do we want to advise people? I think it should be soothe and remove. If we really have an unsettled baby, as soon as they're settled, to take it away, so parents understand not to use it if their baby is happy. And
Exactly.
Oftentimes, if a baby has unsettled quite regularly, we need to see, is there an underlying problem? Because I work with a lot of tongue-tie infants, and many of them have reflux type symptoms where they're gulping a lot of air and they're very unsettled, and parents can't put their child down, and they're arching and really awkward because their stomachs are distended and they're very gassy. So these are the things that we need to rule out, because if we can see, for instance, if there is a tongue tie that is altering sucking and swallowing and leading to those reflux-like symptoms, sometimes we need to address it as an underlying problem, because that can help a child off the pacifier. But yeah, where possible, it should be soothe and remove. And certainly by age 6 months, really it shouldn't be in there during the day at all. I think that there are things like the BB Munchie, which babies can put inside their mouth, and it stimulates the muscles in a much better way, including chewing and getting the muscles to work better, and other sort of toys that they can use. So yeah, a lot of people say that it's okay for the first 6 months, but realistically, we need to understand that it is promoting oral dysfunction.
Yeah. Oh,
I think
thank
that's
you.
I think that's one of the hardest topics to address at young parents, because the pacifier has become so common and so socially accepted that, just like a lot of other habits that we culturally accepted or that are seen as normal, and that people challenge it and say, well, what kind of difference would it make, or how hard can it be? And so maybe I can continue on this question, because that's my quest for the coming years, is going to be like, what arguments or what compelling stories can we use to both convince parents that that somewhere between 6 and 8 months after this adaptation period, and the child apparently is supposedly okay, so there's no need for the pacifier, without getting too dramatically into all the like the worst chain of events that could happen. Like, what are the simple arguments that we could say, like, just take it out? restore nasal breathing at night. Check for that, parents, please. If you do those two things, you're sending them off for a happy childhood. Basically, it's my story. But do you have any things that you know from your practice or from reactions on your book that caught on?
Yeah, I think education really, you know, I'm a dentist and I thought it's all about the teeth. I knew that they cause orthodontic problems. So when I had as a young mum, or not a young mum, when I had my first child and my child was unsettled, it was a lifesaver. Put the pacifier in and you can have a shower and you get into that habit and you think, oh, this can't really create orthodontic problems. But really to understand really the impact on the tongue, how it lowers the tongue posture, it alters the sucking and creates these inward distortion pressures of the lips and cheeks, and really understanding this is when the baby's mouth is the most malleable. So I think really to change people, we have to really help them understand this, not some vague orthodontic problem that could happen later on in the future. But even things like we know that people that use pacifiers are at greater risk of ear infections. You know, the recurrent antibiotic use. It's an altered swallow. It's affecting the way that we clear our eustachian tubes. Or even when it comes to speech development, we need the tongue up to perceive speech, and there is speech delay risk with the pacifier. So just helping people to understand all the different impacts. And even facial mimicry, just being able to watch the different expressions and be able to replicate that. There's even some research on those type of things as well. So there's a lot of impacts that we don't really help people understand that to make that fully informed decision.
Yep. Oh, beautiful. There's so many arguments tied to it that it's it's for me it's been mind-blowing the last 5 years, the relationship between these simple things that we basically do and are fully unaware of the consequences. Nurcan, I saw you ready to continue. Go ahead.
Yeah, I know. I was like wondering if like I already heard you talking about this the way you have a look at it, but then I kind of like assume that you already built like a team around yourself. Is it in your clinic? How did you get the awareness from other specialists to work on this topic? For instance, a speech therapist with myofunctional therapies. But also the ENT surgeon, because we have like a problem here in Holland that they don't recognize the problem. So, for instance, you were mentioning about the ear problems. And then we sent the patient to the ENT specialist, and then we like, okay, can you have a look at it? Maybe we should do something about, I don't know, if it's adenoids or tonsils, maybe we need to remove them to give them more space to, or allergies. That was something that was mind-blowing for me, that it's even more important than adenoids and tonsils. And then they're like, no, they don't have any problems. It's something that belongs to childhood. And then we're like, no, if we won't get this problem solved in a proper way, then it will be a bigger problem for you guys when they get older, and it will be more intervention and more money, and it costs the hospitals more, etc., etc. But they don't, it's kind of like they don't want to understand, and we don't know how to bring this point to them. So how do you work with your team, and how do you get everyone to the same level?
I don't necessarily think that I do that. You know, I do have ENT colleagues who have been able to get on board with this, but they're not necessarily local to me. So they're from different parts of the world. People reach out, you know, they resonate with this. But no, not locally. It's not like I get a lot of referrals from ENTs or opinions. I basically deal direct with the parents. And you know, we see all the kids that have had their ear, nose, and throat surgery, or their repeated grommets or ear tubes placed, and they're still having persistent mouth breathing, teeth grinding, behavioral concerns. That's when we see the patients. And parents have this real problem that they can't solve, but we're able to help them with it. And then they can tell their friends, and, you know, people spread the word and they tell their other professionals, and those professionals tell other people as well. So I think I can't always control what an ear, nose and throat specialist has to say, but if they can hear these things from other people and other people can get that information, what's really important is that the parents are getting the information and being able to access the care and being able to feel empowered to look beyond the ENT for help.
Oh, yeah, that's good. Thanks.
Yeah, I think I'm surprised that more and more people are waking up to this idea now and are understanding, basically also because of what Nurcan is doing and the stuff that we're both sharing, but the platforms that we get available. But I think that, for example, sleep apnea is a very, well, first of all, in adults, it is still treated as snoring is something that is adorable in a child, and look at him sleeping with his mouth a little bit open, etc. You have been involved, Shereen, in this in sleep apnea as well for over a decade. Is there a sort of general advice or like a top 3 things that you would give away to people listening? Like if you are noticing these things as an adult, or if you're noticing sleep apnea symptoms under your children, what would be your top 3 things they could do?
Top 3 things. Well, on sleep apnea, I think it's to recognize that sleep apnea is a very severe dysfunction. It's really the end stage problem. And so it's very reactive to have to deal with it. We just really want to promote nasal breathing. So nasal breathing, it's the key to better breathing and better sleep. So that would be the top thing. We need to establish whatever intervention, whatever surgery, whatever orthodontic treatment, we really need to establish nasal breathing.
Yep.
And when it comes to nasal breathing, it's not just taking things outside of the nose or correcting the internal aspects. We need to recognize that the palate has a very important structural contribution. And so widening the palate can actually improve tongue space and remodel the nasal airway, and we can get that nasal breathing going.
Yep.
Because when we breathe through our mouth, that contributes to the oral dysfunction, to the sleep and breathing problem. And it really is a low tone, tongue down, more floppy airway. So we need to promote, that good closed mouth nasal breathing.
Yep.
So you asked me about the top 3 things.
Yeah.
I guess I would really want to say, promote nasal breathing. Whatever we do, we need to promote nasal breathing. We need to look at the palate.
Yeah.
And the myofunctional therapy, really, I guess, that is a critical part to really promote the habits and muscle pattern as well.
And when you do the myofunctional therapy and you work with myofunctional therapists, is it just exercises, or do you also believe in myobrace and face formers? It's just a sidestep for me.
Yeah, for sure. For children, where we can actually promote better facial development, using those type of appliances that can actually, children can wear it for an hour during the day, and promote better muscle habits. Yes, I think that they can be super helpful.
Yeah.
Sorry?
Is an hour during the day, is that enough, or do you also need use it during the night?
Personally, I guess you use it a lot during the night, do you? Yeah, Jen? Nurcan?
Yeah, now I don't have a myobrace. It's just actually it's a repositioning splint I use right now in combination, because as you can see on my profile, I didn't do my surgery.
Yes.
So it's still a problem.
Yeah.
But I kind of found a way to use a repositioning splint. We call it a performance splint, together with mouth taping.
For children or?
No, for me as an adult. But for children, indeed, we do use a lot of myobraces. But as I talked to Steven, one of the colleagues was already mentioning what we feel or what we see and hear during the night is they fall off. So if you use it, you need to use it with mouth tape, but with children, it's very difficult to do and mouth taping and myobrace.
Mhm.
So the best thing would be during the day.
Yeah, I personally am a bit wary of letting children use things during the night without proper supervision. So I think, you know, during the day, it's critical because
Yeah.
if they cannot seal their lips around them during the day, it will be impossible to wear overnight. But yes, if you can wear it overnight, obviously the duration will influence the muscles for a longer period of time and therefore have a greater impact on growth. So if they can be worn overnight, there is definitely benefit for it, but it's not something I would routinely do. If I think, oh, I want to get, there are some children, for instance, I want to get a little bit more of a V shape and more of a U shape arch after I've done the expansion. I think having those appliances overnight can be helpful, but I really want to make sure they can do it well during the day first. Because I've gone online and I've seen certain posts where people are straight away getting these appliances to wear overnight, and then their kids are having terrors and very disrupted sleep. So that could definitely happen. I want to make sure that the child has good competency closing their mouth before we do anything like that.
Can imagine then you might make it worse when they get these terrors and then they don't sleep at night. And because what would you advise then? Start with myofunctional therapy, and then, for instance, if it's not enough, do an RPE and then go back to the myofunctional therapy, or would you start with RPE and then myofunctional therapy? What would be your advice?
Can you please clarify, Nurcan, for the non-dentistry listener, what an RPA is?
Well, maybe Shereen can
Yeah.
can answer the question within the answer.
Yeah.
All right.
Oh, okay. When Nurcan is referring to RPE, she's talking about rapid maxillary expansion or any expansion that widens the palate. Yeah, and so, yeah, with a screw mechanism to widen the palate, to actually separate the two halves of the palate at the mid-palate suture, stimulating bone. So yeah, the question being, when would I do that? Yes, I would typically try to do that sooner rather than later, because it's less compliance-based. It's a way for me to really get a quick functional shift. When I do palate expansion, I'm typically done within 9 weeks, and it can really make space for the tongue. It makes space for the nasal passage, and children can get really good, quick improvements, whether it be reduced mouth breathing, reduced teeth grinding, just better night's sleep. I want to get that first because myofunctional therapy is very compliance-based. It's not easy. In the past, when I've tried to do myofunctional therapy first, it's too easy for people to go, wow, this is so hard, and then just give up, and you don't really achieve the results that you want. But I think when you've got that quick success, and then parents are more motivated because they want to hold the structural result in place, I think it buys a little bit more time to do the therapy as well, because you've already got quite a bit of improvements. There are certain things you want to do before expansion. I really love kids being very good with the Myo munchie, so I know that they can chew and swallow okay with a plate. I really want them to really identify where the tip of the tongue should be sitting, like on the end spot, and have good ability to lift their tongue so that they know where their tongue should be instead of flicking or messing about with the wires and, you know, playing with it. But yeah, I try to do more therapy after the expander.
That's very good to hear, because here in Holland it's very common to first send them to the myofunctional therapist or the speech therapist, whatever you call it, and then they go to the ortho, do the RPE, and then again to the myofunctional therapist. So it's a little bit different, but in my opinion, as you said, when you broaden that upper jaw and you expand it, you already directly see the difference in the positioning of the tongue, because you give them already more space. That's good to hear. And to continue with that, do you work also with sleep centra for children, or do you only know that phenomenon for elder people? Because here in Holland it's very common, if you have OSAS or if you have sleep apnea, you send a patient to the hospital, they send them to the sleep centers with these electrodes and just have a look how they sleep during the night and if they have breathing stops and that kind of stuff. But for children, it's very uncommon in Holland to go to a sleep center to let them be examined for whatever might be a problem. Do you do that in Australia, or have you been do you have sleep centers in Australia for this problem with children?
Yes, there are definitely sleep centers to get sleep testing, but sleep testing is, often when we get the report back, it's quite insensitive. They're saying the child has sleep apnea or they're not having sleep apnea. Despite the vast data that's available from the sleep study, parents can get this very understated result, yes or no, sleep apnea. But I actually believe that we should be ensuring children can breathe through their nose. Nasal breathing is the measure. We want to help children get nasal breathing, and I don't need necessarily a sleep study for that. And if I send them and the parent is told there's no sleep apnea, then it doesn't really emphasize the need to restore nasal breathing.
Yeah.
And I think that when we can get children to close their mouth, we know the research tells us that even mouth breathing alone, there's increased risk of attention and hyperactivity, inattention and hyperactivity type of symptoms. Yep. So we need to work on the nasal breathing.
Yeah, true.
Yeah, so the nasal breathing for me, of course, is a logical step and a very big part. And whereas both of you and also my profession is basically around treating symptoms of poor breathing habits and then trying to restore them as good as we can, and you even having some more extra tools at hand in expanding and modifying things in the jaw mouth region. I get problems as a guy, even though being a father of 3 and supporting my wife during breastfeeding, but I get a lot of shit from especially the female audience if I am the guy talking about breastfeeding and the importance in relation to jaw development. So maybe Shereen, if you will, because this is for me one of the big topics on the prevention part, whereas that we can inspire to be moms to give this a go. And especially from your side, like what kind of timeline would we be looking at that breastfeeding is looking for the jaw development, tongue position, etc. What would be beneficial for them in order to get this jaw nice and wide and strong and nasal breathing developed? Could you elaborate on that maybe?
Yeah, we want optimal latch. So it's not enough to say just because a baby has no pain or there's good weight gain, it's not quite good enough. We want the tongue to be working efficiently. So really, to efficient transfer of milk, it's created by tongue suction. So the tongue suctions to the roof of the mouth. So it's really pushing that breast tissue and molding the palate nice and wide. And as the tongue lowers, it creates a vacuum. And that's when milk comes out the most efficiently. And for the baby to do this, it requires a complex coordination of all their muscles, including the jaw, the lower jaw moving back and forth. So that stimulates the lower jaw, as well as being nature's palate expander. And when children are transferring milk like that, they can regulate their suck, swallow, and breathe. So they can do all at the same time compared to having a bottle and slowing down and having to mouth breathe and pause, etc. So yeah, it's just, we want to have a good deep latch that utilizes the tongue. So anytime we see, it's possible to extract milk without using the tongue, you just use your lips and cheeks.
Yep.
That creates a whole set of other problems where the tongue is actually not being utilized. So I think really having a good lactation consultant that is really aware of the mechanics of good breastfeeding and will really look for the latch. And, if things aren't going well, to be able to recognize there may be a tongue tie or, what are the other factors that may be involved in not allowing that optimal latch.
Yeah. Yeah, I use these sort of stories to bring this point home, to say to parents, like, we want to give our kids the best, and that for our feeling, it means like giving them proper nutrition or taking them to the playground or to beautiful campsites or wherever. But based on your book and also the book written by George Catlin, I'm assuming you've heard of, Shut Your Mouth and Save Your Life. I try to always teach young parents basically, because dads play a big part in this as well, is that just watching over your child during the day and during the night and just ensuring this habit when they're gaming or when they're reading or when they're asleep or when they're in the back of the car, and just learn them this pattern. But also the importance of breastfeeding in order to get all this muscle structure and this jaw development done right. Do you know from science? So let's talk from the men and women in the white coats. What is an appropriate or suitable time that breastfeeding has these benefits and that it's okay to transition to other forms of lactation and etc.
I think well, they generally promote that there is immunological benefits to try to go to 6 months. I'm not quite 100% sure about the duration in terms of jaw development, but what we do know is from anthropological studies, there is definitely the shrinking of the human face and the jaws, and that has increased the prevalence of crooked teeth, and that's really coincided with the Industrial Revolution, where there was more formula feeding and, puree foods and pacifier use.
Yep.
And so they really compared that with the traditional populations, which could breastfeed for up to 3 years, and had very little incidence of dental crowding. So that longer duration seemed to help with
Yep.
it. Not that it's necessarily practical, but
No, it isn't, but yeah. No, well, that's the hard part. It isn't practical in the short term. At least that's how we feel it, because it intervenes with social life, with work, with everything we want to do. So my second child, he was breastfeeding for I think almost up to 4 years. So yeah, is it practical? No, but learning from Nurcan and from you and from other specialists, like, wow, it's a big gift my wife gave my child in this case, and to see how he develops.
Yeah, and Steven, I think it's really important as well, because some people can't breastfeed and we don't really want them to feel guilt, and that to recognize there's so many other factors and so many other opportunities that we can optimize the oral development as
So maybe we
well.
can elaborate on that as well. So let's say breastfeeding is for various reasons a hard station to go to. You already talked about food and how that developed. So one of the things I recommend everybody is chew hard things. Just are there any foods that you would recommend or that you know that kids could use, or toys or other stuff that could help jaw development in those early years?
Yeah, I really love the Mayo Munchie.
The
I
Mayo-
nearly want to issue that to every single patient that we see, and they have a baby version, because
Yeah.
that's good chewing exercise. And I like the idea of baby-led weaning. If I was ever to have grandchildren, I would encourage my children to do that. It makes a lot of sense to give them finger foods rather than do the purees.
Exactly. Let
Yeah.
them chew, let
Yeah.
them use the jaws and use the mouth. Yeah.
Yeah.
Is there anything, Nurcan, that you recommend to patients or to parents in the Netherlands?
Yeah, well, basically in Holland, when patients come in with their children, because that's what I said, sometimes you see them from a very young age, sometimes you already see them quite later on an age of 3 or 4. And that's when patients come in for the intake procedure, we always ask, how many times a day do you eat? And the second question is always, what do you eat and how do you eat it? To be aware of if they really eat all the bread, and if they don't peel everything, and the consistency is the same. So we basically do the same here, but it's still a topic that's a lot of dentists don't even ask for when their patients come in the dental practice, because you only have 5 or 10 minutes to do the checkup, and then you don't ask any questions of that. And then all of a sudden the patient goes home and no one knows about their habits. So we do kind of like the same as you already mentioned, Steven. And I guess you kind of like learned it from me, isn't it, Steven?
Yeah, no, totally. So for a lot of lessons and a lot of slides that were yours once is what I'm using now. So it's very grateful both of you to be on this journey and on this path of getting this knowledge out there. And well, I always tell I come from a marketing background, and I chose the hardest career right now, and that is making the positive and negative effects of moving air in and out our body tangible. So showing people the positive benefits, how you can use it to alter mood, recovery, sleep, but also the negative effects of what, and especially if in those first 10 years of a child's life, breathing habits are not optimal, how that can influence life later on. So maybe Shereen, on that topic, because I prepared a couple of like out of the ordinary questions, like let's say you would get a big amount of money for a dream project to create awareness on this topic. How would you spend that, or how would you use that to create more and more awareness, if I may ask?
That's such a big question, Steve. And even though you prepared me, I still feel very unequipped to answer this. There's various different ways, but I don't even know if they're the most impactful.
Yeah.
But yeah, I'm a big fan of Dr. Steve Carstenston. I don't know if you're familiar with him. He's a dentist in the US. He was actually really responsible for approaching the American Dental Association. And they have a 2017 policy statement where every dentist should be involved in being able to screen for airway and sleep problems and be able to help their parents, help their children, whether through referral to other professionals or themselves to develop healthy physiological airway. So promote nasal breathing and really being able to influence the whole dental field in America to learn more, to inspire them to learn more, because we are dentists and we can identify so many of the red flags. So I think that was really a great initiative and very influential. And it would be really great to be able to do that amongst other professionals. You know, pediatricians, to be able to help them to identify these airway issues before medicating for ADHD. You know, speech pathologists, like all of us healthcare professionals, should really play a greater role in managing these problems, because a lot of the time we are seeing children for speech therapy for 3, 4, 5 years, not getting anywhere. You know, these medicating, so many kids getting melatonin, they're not sleeping well. Nobody's really looking, are they fight or flight mode because of this chronic stress of breathing problems? You know, the ADHD medications, you know, OT, psychology, all of us seeing these problems, we may not be recognizing underlying airway issues. So what he's done has been fantastic. It would be great to promote that amongst all different healthcare professions. You know,
So
their children get the
would
hearing
be,
test.
your focus would be on your colleagues and in the professional field, getting this topic more broadly known and have them be able to share these insights with the patient, with the patient's parents, and get it. Wow, you know, and it is a hard topic to tackle, because so many people make jokes when they talk, but it's air and it's how you breathe, and how could that even be of like the tiniest importance? And maybe if you do you have a case, because that's one of the other topics that I'm personally interested in, is learning behavior or learning capabilities and behavior in primary school, basically, and how that is affected through breathing habits or breathing problems. Any cases that you or that you've seen in your practice and that you've treated with success?
Yeah, absolutely, all the time. You know, when children don't get refreshing, a deep good night's sleep, it affects their attention and their concentration, their ability to take in information and learn. So yeah, definitely, I feel that all the time when we can help a child breathe better, yeah, it's something, helping children manage their emotions during the day, so they're more calm and settled and learning. Parents love this, it's something that is so important. And yeah, any specific cases? No, it's something that happens, we see all the time.
Yeah.
Yeah. Wow.
Because that's
So
something we face
not
a
a
lot.
specific case. It's a general line of that you can recognize as a pattern.
Yeah, well, she's right, because what we kind of like see is that a lot of people, when they come to the practice and you ask for the general health, and then they are always like, oh, my child uses these and these medication for ADHD, and they're always very busy, and the teacher's complaining, blah blah blah. And then the first question we always ask is, how does your child sleep? Have you ever been watching your child sleep in their room?
Yeah.
Do you hear them snoring? Do you hear them? Sometimes you don't even hear them snoring. Sometimes it's just mouth breathing. You don't even hear them. And then I'm like, yeah, just go and have a look. Is the mouth open or not? Because even if it's open, they don't get into that deep sleep. So they don't recover. And if they don't recover, they're anxious all day. They're busy all day. They're trying to compensate all day. So it's not like one specific thing. You hear that all the time. And that's also one of the things I wanted to ask, like, what's the biggest misconception in this whole thing? Because when you're trying to tell a parent, maybe you can stop using those medication for ADHD, and just have a look at the sleep, try to do mouth taping, do the exercising, etc. And then they're like, no, but the doctor said that it's better to use the medication, because we're just dentists telling them it's the other way around. So what's your biggest misconception on this thing, or what are the biggest misconceptions on these things?
Yeah, I think anytime a child is displaying red flags of mouth breathing, snoring, bedwetting, teeth grinding, those really key red flags, we should try to address the airway. Yes, I think not every case of ADHD is going to be resolved with it, especially some of the kids that I think physically act out. But if we can get a child sleeping and breathing better, I think there's really no harm in that. And often, there's a massive wait list to see a pediatrician to get medicated. It's like a year plus. So why don't we just try to see what we can do to get children's breathing better first?
Wow, is it a year plus in your country?
Yeah. What about yours?
Oh, no. Here, if I refer patients, it's like maybe 4 weeks, maybe 6.
Okay.
Something like that.
No.
Yeah, no.
Yeah.
They can get easily in. If we refer, they have an appointment within 4 to 6 weeks.
Right. Yeah. Yeah.
Yeah. But it's, of course, it depends on each country.
Yes.
The main insights for me from your book was, and I just want to pinpoint out because of it's so important, was that here we have, and I'm sure in Australia and in the United States as well, beautiful, I think it's called childcare services. So either when they're not going to school or after school, childcare, all these kind of places where kids can go. And here, sometimes as young as maybe 10 to 12 weeks, our babies already go there. And they always come home with this big snot bubble. And everybody here says, yeah, but it's good for their immune system. They're nicely getting used to all these different bacteria and viruses, and they'll have a proper immune system for the rest of their life. And I never realized that the same snot bubble basically forces them to breathe through their mouth for more and longer periods of time than would be necessary if they were to play with less kids or in better ventilated environments, correct? That's the thing I took from your book, and I would love for you to comment on that and tell us a little bit about these insights and what you know.
Yeah, I think Yeah, definitely. Like when children have that runny nose, we can look at the nasal sprays and aspirating that and keeping their nose clear.
Yeah.
Yeah, I think it's something that we should be looking at. Yeah, and when they go to daycare, like, can they close their mouth? Simple things like getting a paddle pop or a thing stick that they can close their mouth around. Just really simple things, I think, we can pay attention to. Yeah, because they will come, if you breathe with your mouth open and not through your nose, you will come back and pick up everything,
Yeah.
because you're bypassing that first line of defense,
Yeah.
first line of the immune system, which is really the nose.
Yep.
Yeah.
So realizing this, would that be coming back to the question, let's say you get 500,000 US dollars,
Yeah.
but would childcare professionals, would they be a good group to address? It's also a question for me personally, because I'm
Yeah.
developing this plan for here in the Netherlands. Would you say like target childcare professionals with this knowledge?
Yes, I think there's so many people that we could target, definitely. Even teachers, early childhood educators.
Yeah.
Because, they're the ones that are paying attention to, they're managing the difficult behaviors or the inattention as well. So for them to have a good understanding, there's so many groups that we can definitely approach.
Yeah. Yeah, so for me, I think that is the top three is the dentistry professionals, the people that work with kids at the early age. So basically childcare and primary education professionals and parents. Those are for me like the 3 or 4 groups that I've identified, like, okay, we have to get your story. So I'm like I said, I'm very grateful. I toss it around everywhere here in Holland, and
Thank you.
I leave it everywhere on tables.
Or blueprints.
Yeah, exactly. But if and I understand, for me this is something that comes easy to make emotional statements or emotional addresses. But as a dentistry professional, Shereen, if there were like recommendations that you would give to young parents who are listening right now, and also like to sum up a little bit our talk of this hour, what would you recommend them? Like if you want your child to grow up healthy, field of work, what would you advise them?
I would actually advise them to read, breathe, sleep, and thrive. Have it as their reference from the moment a child is born. What are the red flags of feeding problems? How can you know how well a child is breathing or sleeping during the night? What are the key red flags? What are the key red flags in the mouth, in terms of their developing bite and orthodontic situation? And then therefore, where are the pathways they can go through? So yeah, I think that Children's Airway First Foundation, I really like the resources they're compiling as well.
Nice. Children's Airway First Foundation, you said. That's an
Yes.
Australian initiative?
No, it's an American nonprofit organization.
Yeah.
Wow.
Yeah.
All right.
That's the one from Cartonston, isn't it?
No, that's Candy and Brad Sparks. They had a daughter that had airway problems. And so they've done this foundation to ensure that no child has to go through what she had to do by focusing on early identification and management by age 6.
Wow.
You need
Beautiful.
to be aware of that one, Steven.
Yep, I am. You put it on my radar right now. And a personal question, or personal but professional question, because I work with breathing 24/7. So I retrain breathing habits. The youngest child I worked with was 5 years old. I do funny kind of exercises, because what I realized is that you have the power to expand jaws, to retrain muscles in the mouth, develop speech, etc., or to refer to professionals. What I've come to realize is that if breathing for some reason is maladjusted, or like our internal thermostat for breathing patterns is off, I do a lot of those funny exercises. So take a big breath of air and have the kid walk as many steps as he can, and then drop a ball or an object so that he knew how far he got, and then see if we can beat that process in order to get them aware of the, that the unease of not being able to breathe properly is not that scary or not that terrifying, because it's so I love the age between 5 and 10 because everything is playful. But are you referring to, or is there a growing awareness in Australia of breathing professionals that do these kind of exercises or training with kids or with professionals?
Yeah, I'm not sure that we over focus on it, but definitely things like James Nestor's book and yeah, I think that has really got a lot of people interested.
Yeah.
I really do think that we should be paying more attention to that in general, the diaphragmatic breathing. So we will introduce it to some patients that we think need some extra help, but that should be fundamental for all of us, you know, just not just for the breathing. I mean, to relax our whole nervous system down, how calming it is if we could just take that time out to do the breathing. And it's super helpful. Today, even like one of the patients had some gagging problems, and my assistant did some belly breathing with her so she could cope and tolerate with all the photos and mirrors. Or if we're doing a tongue tie procedure and we want to keep a child relaxed, you know, how easy is it for them to manage when they're doing really good belly breathing and training? Yeah, it's definitely something we need to pay more attention to.
Yeah, no, that's thank you. I think that's one of the things. Yeah, it's my profession, but it's it's my path that I'm on. So, and I'm grateful that our paths joined today on this call. Nurcan, do you have any questions or remarks for Shereen, because time is flying?
Yeah, I do. For us, your book is a blueprint, but if you would ask parents when they come with their children for the first time to the practice, what would be the first 3 questions you would ask? And what would be your first, or what would be the first 3 questions you would ask? And which doctors or which professionals do you want in your team to reach that bigger goal? So 3 professions and 3 questions.
Okay, 3 questions. Well, you know, breastfeeding is the foundation for good oral muscle function as well as good jaw development. So I'd want a really good lactation consultant who understands this and can help with oral exercises to help get the mouth working better. So definitely that's one question.
And one specialist.
Breastfeeding and what other questions? Gosh, yeah, really. I think it's really hard to narrow down to 3 questions, but the sleep and breathing, having a quick list of symptoms that parents can be aware of. And who would I want to refer to? Well, you know, we obviously take care of the palate expansion a lot. I think it has a central role. You know, we need to refer often to ENT specialists, but I still believe that even when we do things like adenoids and tonsils, I feel the root issue often is dysfunctional breathing precedes that. They are symptoms of a problem. So we still, as dentists, have a really important role, one of the most important roles, to optimize the airway and get to the root of the problem. So yes, dentists are another person that I would refer to. And then the myofunctional therapist. I think the myofunctional therapist is really important to help retrain the habits and promote nasal breathing and closed mouth and good tongue function as well. So they would be the 3 professionals that I would refer to. But
and
the questions,
one last question, just one. Do you use standard forms for parents when they come into your practice? About
I
like
do
what
have
kind of
I
signals
do.
you see?
Sorry, what was that?
Like, for instance, what kind of signals would be seen if you have a mouth breather or a nose breather?
Yeah, I have a questionnaire. I have a questionnaire that they fill in, and it's really just a
Yeah.
prompt. Think about it. But once they come in, I do a full interview as well. I'll start from
Yeah.
breastfeeding and, solids, history, speech, ear infections, ENT history, like go down the line. And then lots of questions about their sleep and lots of questions about their daytime function as well.
Yeah. Okay.
Yeah.
Wow.
I think it's really useful to speak to parents, to get to listen to them and tell their stories. We can often find out a lot more than just a simple form.
Yep, agreed. This combination is very powerful to both have
Mm.
help them identify a couple of things, but also have them elaborate on behavior and things that they see in their child specifically.
Nice.
Wow. Shereen, for you, any final words to the audience here in the Netherlands before we wrap this up?
No, we've covered a lot of ground and
I think
had a
so.
few questions that was put me on the spot. Thank you. But really, I just want to I want to show my appreciation to you, Nurcan, for really discovering the book and passing it on to Steven and having me be a part of this interview and getting to have another opportunity to promote airway health to a new audience. So thank you so
Well, the
much, guys.
nicest, that's
Appreciate it.
good.
Yeah.
Thank you very much. Because the nicest thing you could do to us is pass this book to us, because we are sharing stage in Holland a lot among dentists. And I share stage alone as well among dentists. So the first thing I promote is the book, because it's our little child Bible.
Yeah, it is.
Thank you. That means a lot to me.
We'll
that
be sharing
Thanks a lot.
We'll be
Yeah.
sharing links to the book and to the other things that you've referenced to below this video that we're going to put online. And yeah, thank you. So I think Nurcan and I, we might take it as an opportunity to see where we can invite you, Shereen. If you ever come to Europe or if you have Europe plans, let us know in advance, because we have the network here to get you up on stage. And otherwise, make it a reason to get you here and fly out all the way to tiny Holland, tiny but influential Holland. And we're going to be using this, your book, your knowledge, your energy, to open up more doors here in the Netherlands about this topic, address it more, and different playing fields and well, the groups that we've identified. So thank you so much for giving us basically a little more weight on this journey and getting this message out. And thank you so much for your time, and we'll be in touch on nice things to follow.
No, thank you.
Thanks
Thank
a
you.
lot,
It means a lot to me.
Shereen.
Thank you.
Thanks.
Yeah.